Today we will be discussing infantile pyloric stenosis, which is one of the most common surgical cause of vomiting in post-neonatal period. So in common terms, pyloric stenosis is a narrowing of the opening from stomach to duodenum, which is known as pylorus. It is most often occur in the first few months of life, so invariably it is termed as infantile hypertrophic pyloric stenosis. Some of the people also term it as congenital pyloric stenosis, but since the situation develops after the birth or symptoms appear after the birth, usually after 4th week of life, so it is more appropriate to term it as infantile hypertrophic pyloric stenosis. The typical presentations occur at the age of 4 to 8 weeks, and it is almost found to have in 2 to 3.5 per 1000 live birth. In this case, the pylorus gets obstructed because of the hypertrophy of the muscle, and the patient presents with the feature of gastric outlet obstruction. Coming to the historical perspective, it was first described in 1627 by Landus. Then it was confirmed by a player in 1717, but the first time Harald Hirschsprung gave the description in 2 infant girls and proved that this is a hypertrophy of pyloric. 1912 was the year in which the revolutionary change in the surgery, hence in the mortality associated with this disease, has been decreased drastically, and the surgeon was Ramsted, and since then the surgery is known as Ramsted Pyloromyotomy. It was an incidental surgery. Coming to the epidemiology of the disease, it occurs in 2 to 5 per 1000 live birth. It is relatively less common in the black Asian, but it is more common in the males than female, and the ratio is 4:1 to 6:1 in different parts of the world. It has been associated with B and O blood groups, and in these blood groups the patients usually have more incidence of hypertrophic pyloric stenosis. These patients, the babies which are born to the elderly mother are less likely to be affected with this abnormality. The genetics is polygenic, and there is 5-fold increase in the risk. It has been seen that in monozygotic twins, it is almost 200 times more common than the normal population, and in dizygotic twins, it is 20 to 30 times more common than the normal population. The seasonal variation also has been seen in these cases, and few of them are associated with TOF. Male and female children of affected mothers carry 20% and 7% risk of developing this condition. So it has some genetical relation. Etiology is primarily unknown. Few said that if a macrolide has been taken in pregnancy, it may lead to this disease. Increased activity of prostaglandin has also been associated with the higher increase of this disease. Similarly, in the cases where hypergastrinemia is seen, is also associated with increased frequency of incidence of this disease. Coming to the normal anatomy of the stomach. As you can see here, this is the cardiac head, incisor or cardiac, fundus, body of stomach, then there is pylorus, and this is the main region of pylorus where the pathology occurs. This is the first part of duodenum, this is the stomach. So the joining part of stomach to the duodenum is known as pylorus, and the pathology occurs here in these cases. Coming to the anatomy in cases of idiopathic hypertrophic pyloric stenosis. The muscle of pyloric antrum is hypertrophic, that is, the size increases for more than 3 mm and separate the normal antrum from the duodenum. The lumen is filled with compressed and resultant mucosa which obstruct the passage of the gastric content, hence leading to the gastric outlet obstruction. You can see here that there is hypertrophy of the muscle, mucosa remain normal, and hence there is difficulty or the passage of food is obstructed here, leading to the abnormality related to gastric outlet obstruction. Coming to the clinical presentation. Typical presentation in this condition is the onset of vomiting, which is non-bloody, always non-bilious, at the age of 4 to 8 weeks. As the obstruction increases, the intensity of the vomiting increases and until it reaches to the pathognomic type of vomiting known as projectile vomiting starts. After vomiting, the patient is very hungry. There is vicarious appetite in these patients, but as soon as the patient takes food, he vomits. To wet and way, whenever he takes the milk, he vomits. Patients are usually ill-looking or febrile. These patients are associated with hypokalemia, hypokalemic metabolic acidosis, alkalosis with paradoxical aciduria. Sometimes it is associated with jaundice, which usually subsided after the surgery or once the patient has been operated. This symptom is gone by itself. Coming to pathology. In comparison to normal pyloric area, the IHPS specimens, the muscles are deficient in number of quantity of nerve terminals, markers for nerve supporting cells. They depleted in peptide containing nerve fibers, and they decrease mRNA production for nitric oxide synthesis and their interstitial cells of Kadar. So this is the abnormal pathology in the cases of hypertrophic pyloric stenosis. The muscle and the mucosal area are deficient in nerve terminals as well as the nerve supporting cells. Similarly, there is increased insulin-like growth factors, that is mRNA. Coming to pathophysiology in these cases. Vomiting lead to the loss of acid, hence result in alkalosis. The chloride loss result in hypokalemia, which impairs the kidney ability to excrete bicarbonate. Hence, there is dual-fold retention of bicarbonate, leading to alkalosis. Since there is loss of water, there is secondary hyperaldosteronism, which, as I have told you, occurs due to hypovolemia. Increased aldosterone level causes kidney to retain sodium, and once the sodium is retained, the potassium has to go out, leading to hypokalemia. Since body compensate for metabolic alkalosis, which leads to hypoventilation, and this lead to increased level or elevated level of carbon dioxide in ABG. Coming to the diagnosis, the hallmark, as I have already told you, is the clinical presentation, that is projectile, non-bilious vomiting, and patient is hungry after vomiting, and it's confirmed by clinical examination if you are able to palpate a pyloric mass or pyloric tumor. This pyloric mass is olive-like tumor, and if it is palpable or palpated, the diagnosis of the disease has been made. No further investigations are needed, in fact. So, to examine or to palpate the tumor, it is very important that patient should be calm and cooperative. It is better if stomach is deflated. So, keep the patient in the supine position, and examiner put the child left side, gently palpate the edge of the liver and at the corner of the or edge of the rectus abdominis muscle, and this will help in palpation of pyloric tumor. The tumor is best felt after vomiting or during or at the end of the feeding. Coming to the investigation, sonography is considered as one of the most important diagnostic tool for diagnosis of idiopathic hypertrophic pyloric stenosis, and there are a number of findings, but the most important one is the thickness of the pyloric muscle wall. So, if the thickness of the pyloric muscle wall is more than 3 mm, it is diagnostic of hypertrophic pyloric stenosis in such cases. Second important thing is the measuring the length of the pyloric canal. If the length of the pyloric canal is more than 14 mm, it is considered to be a case of pyloric stenosis. In normal individuals, it is less than 12 mm. Coming to the pylorus diameter, if it is more than 12 mm, it is considered as pyloric stenosis. And since it is hypertrophic muscle, there is increased vascularity in the pylorus mucosa and muscle. When the pylorus muscle wall thickness is less than 2 mm, it is normal, but if it is between 2 to 3 mm, it is considered as equivocal cases, which may or may not have this disease. So, this is the sonography feature showing how to calculate or how to measure the length of pyloric canal. Similarly, pylorus in transverse plane gives a target side appearance. This is the thickness of the muscle mass, and it gives a cervix sign appearance. Due to the bulging of the mucosa, there is a nipple sign which is difficult to appreciate, but it is one of the important signs in sonography. Here we can see the increased vascularity in the mucosa and the muscle of pyloric region in the cases of idiopathic hypertrophic pyloric stenosis. Though no other investigations are required for the diagnosis of idiopathic hypertrophic pyloric stenosis, but if or at all there is confusion, upper gastrointestinal contrast study may help in the diagnosis of the disease. There are a number of features which help or which suggest that this is a case of idiopathic hypertrophic pyloric stenosis. One of them is a string sign, which is one of the most important signs in cases of barium diet study. There is a thin canal and passage of contrast through this thin portion or narrow portion give an appearance of a string between the two, and this is a string sign. There is maybe a double track sign or it may be a shoulder sign. Shoulder sign occur due to the duodenal mucosa. You can see here. This is the shoulder sign. It is one of the important sign or finding in the cases of upper GI series. One can do the upper GI endoscopy, but it is not indicated for this disease. And if the nasogastric aspirate it is more than 10 ml, IHPS is considered. Now, coming to the differential diagnosis, the most important diagnosis is gastroesophageal reflux disease. Another is adrenal insufficiency. For vomiting, it is viral gastroenteritis and involve error of the metabolism. There may be a pyloric membrane or duplication, and it may be due to duodenal stenosis. If stenosis is there in the first part of the duodenum, leading to non-bilious vomiting, which may be a projectile. So, this is all for the diagnosis of the disease. Coming to the management portion. So, as we have already seen, that it is a surgical cause of vomiting, but the patient should not be hurried for the surgery, and initial management is of utmost importance in these cases. Since patient is vomiting and not accepting orally well, there is a loss of acid and lot of electrolyte imbalance and pH disturbance occur in these patients. So, first of all, we have to correct the fluid, that is depletion of the fluid. We should chlorize the acid-base balance and maintain the electrolyte. Initial therapy should begin with half or normal saline with addition of potassium chloride as per the need. And patients should not be operated till the electrolytes are within normal limits. Fluid therapy should be continued until the infant is rehydrated and the serum bicarbonate levels are less than 30 milliequivalent, preferably less than 27, but if it is less than 30 milliequivalent, he can be taken for surgery. Which if it is normal, it implies the alkalosis has been corrected. Once resuscitated, the infant can undergo the Ramsted Pyloromyotomy, that is fitted Ramsted Pyloromyotomy, and it's considered as procedure of choice for these cases. Benson and Alpern described a severity index for the management of pyloric stenosis, and it depends upon the bicarbonate level and carbon dioxide level in the body. And according to the severity, when the correction is there, it comes to the lower grade, and then only patient can be operated. If the Benson and Alpern score is high, that is 4, it is not safe to take the patient for surgery. Coming to the history of surgery. Initially treated by gastroduodenostomy or gastroduodenostomy, that was a major surgical procedure for infants, and the mortality rate at that times are very high. Therefore, in 1908, advised splitting of the hypothalamic muscle up to the mucosa and closing mucosa transversely. And it was the Ramsted which in 1912 advised splitting of the muscle up to the mucosa and leave the muscle as such, that is not to put or close the pyloric muscle. If the mucosa entered, which usually occur on the duodenal side of the pylorus, can be primarily repaired and reinforced with omental patch. Few of them say that if there is perforation, you should close the muscle and do the pyloromyotomy on opposite side. That is also true for large perforations. So in this case, close the muscle properly and rotate the pylorus 90 degree and repeat the myotomy. These are the steps of Ramsted Pyloromyotomy. In this figure, the pylorus is taken out of the incision or wound site. You can see the olive-like tumor, which is to be held properly between thumb and the index finger of left hand. A small incision is given or made on the muscle, and the muscle are spread apart until the mucosa is seen. It is better to spread. You should use the pylorotomy further. And the procedure is complete if you are able to see the properly bulging mucosa through the hypertrophic muscle which was incised and separated. Here you can see easily that the mucosa is bulged properly. After surgery, diet can be resumed within 6 to 12 hours post-operatively. At our center, we prefer to start the feed at least 24 hours after surgery. Post-operative vomiting can be seen up to 50% of the infants after surgery, and most of this vomiting subsides by its own and may be due to the atonia of the stomach because of acute dilatation of the huge dilatation of the stomach. Few authors have suggested endoscopic balloon dilatation leading to in which the cerebromuscular ring has been disrupted for endoscopically, but it is not a treatment of choice till now. Few authors have advocated for giving atropine sulfate with varied level of success, but still or till now the Ramsted Pyloromyotomy is the gold standard treatment for hypertrophic pyloric stenosis. So few studies have been carried out in India also regarding the atropine sulfate uses. Singh et al. From Patna have shown that there is 96% of improvement in the patient who has been of idiopathic hypertrophic pyloricin who has been treated with atropine sulfate, and Khara et al. From Japan has given a ratio of 87%. But the best results are seen with surgery, which is a definitive treatment for this disease, though recurrence can occur in these after surgery also. So, coming to the post-operative complication in these patients. The most common complication after surgery is vomiting, that is persistence of vomiting beyond 48 hours, and it is seen in 3% of the cases. It has been observed that these complications, which that is vomiting after surgery or persistence of vomiting beyond 48 hours surgery, may be due to the atonia of the stomach and it subsides by its own, or it may be due to incomplete splitting of the pyloric muscle, hypertrophic muscle. Though if the feed has started earlier, few patients may vomit, but it is seen that usually patients accept feed or full feed after 24 to 48 hours. Second most important complication is wound infection, and these patients have a high rate of wound incidence. The cause of this high incidence is still unknown. In the cases in which incomplete myotomy is suspected as a cause of persistent vomiting beyond 48 hours, may subject for repeat myotomy or may be candidate for endoscopic balloon dilatation. Though few authors have their view that in these cases atropine sulfate can be given and it is very important, or it may resolve the problem. Thank you.